Let's talk, you can relate to this living in where you do in Idaho. Let's talk a little bit about rural healthcare and the future of rural healthcare. There have been some statistics that have really been eye-opening for me in particular. In 22 states, 25% or more of rural hospitals were at immediate risk this past year, according to Becker's Healthcare article from January. It's an underserved community in a lot of ways. This pandemic has really tapped them out in a lot of respects, and and I imagine they're struggling to make the bottom line work, and really faced with some challenges. I think you've seen them over the years. You've got some of these rural community hospitals that have dug their heels in strong to remain independent. They absolutely do not feel that it's in their community's best interest to sell to the big system down the road or to some of the for-profit systems or whatever.
Effects, yeah.
But they're feeling pressure to look at those alternatives now more than they ever have. And so it'll be interesting to see how all that plays out.
Yeah, Bill, you asked me about that because that's in my world, rural. But on the other hand, we forget sometimes that a lot of these rural hospitals are already owned by bigger health systems, and I work with so many of them. Here's kind of my thought. Even in Idaho, they lose their identity as a community hospital. They become nothing more than a referral center to the big hospital. And when that happens, the community doesn't support their hospital anymore. They become a little hostile. And those in the rev cycle, we've got to collect bills. We've got to get patients to want to pay their bill. And what is the backlash? Well, nobody in the community, nobody even is at our hospital anymore to talk to us. It's all over in Boise, or it's all off in, like HCA's in Vegas in the West. And so the communities who used to have a person to talk to, they go to the webpage. Just go to the webpage. Or they call some number that's an outsourced revenue cycle who lives in Illinois, doesn't know the first thing about Idaho agriculture world. They lose their identity. Mm-hmm. And the worst thing that's happening is these rural hospitals do have to join the bigger health systems. The bigger health systems need to reflect a bit. They are not just a referral system. Right. They have communities, they have jobs. When you look at some of our 1,300 critical access hospitals, they are the jobs that pay well in that community. Absolutely. So if you shut the hospital or shrink it down and send everything to the Papa Hospital 2 hours away, you don't just use the community hospital, you lose the sense of community that our rural hospitals bring. Now, does that mean they can continue to stand alone? Idaho's couple of our standalones they made the news about how much financial risk they are at right now. Mm-hmm. And they're holding out. I know I work with some great hospitals, critical access all over the country, and they're holding out. They're sure they can do it. And I don't know if they can do it, but I would say to the bigger hospitals, treat them with respect.
What are you hearing about some of their volumes in the rural hospitals rebounding back to what it was either pre-COVID? Is it quite there yet, or still a little ways to go?
Patients are still not coming back the way they did. So then you have to decide maybe they shouldn't have been there to begin with. That is kind of the conversation that's out there. Yeah. So but also Washington State is having their fourth surge. They just announced it. They've had triple the cases in 1 week. The state of Washington, Michigan shut down their elective surgeries. They're just starting them up again because they had a big surge. Until we stop the spread, it's going to continue to hurt people. Other hospitals, though, it was really interesting at the Iowa HFMA chapter. One of our conversations was about the rural, lots of rurals there, and it went all over the map. It was very interesting. It depends upon where you were at in the state. In Idaho, it's the same thing. In our super rural areas that don't have a lot of exposure to anywhere else, mm-hmm. not much change. They still have a census of 4, and they still have, but it really depends upon your exposure to other areas as to how bad and how fast you're coming back. Telehealth is here to stay forever. So we just have to figure out how those practices are going to be okay with telehealth.
Sure.
Because a lot of our rural hospitals own their physicians. They employ them. So they got hit twice. They didn't just hit the hospital volume, they got hit with their doc volume.
Right.
And some of the commercial plans in Medicaid, we had hospitals that said they're no longer going to do telehealth with United or their state Medicaid, managed Medicaid plans, because they're paying so little for telehealth. Mm-hmm. So now they've said, we're not going to do that anymore. It's like, come on, let's stop this.
Yeah.
But that's what, and of course, the rural hospitals, are they coming back, Bill? It tends to ask the part of the country you're in, and the answer would be different.
Yeah, they're in some respects, they're going to have to reinvent themselves in a way that they may not even know yet, but this has certainly pushed them to think out of the box in a lot of different ways.
For
Let's
sure.
shift gears a little bit just to some of the hot topics in revenue cycle. I know you've got a session topic, payers gone wild. I'm sure you could go on for a long time about some of the issues there. Talk about anything in particular that you think some of our revenue cycle peers and friends need to hear as they're trying to be productive. Work from home is alive and real. It continues.
Yeah.
Here today. It seems to be working for a lot of organizations. But what are some things that you'd like for some of your revenue cycle peers to know about and be thinking about as they move forward and try to continue to be fiscally responsible and keep their organizations healthy?
Yeah, what a challenge that statement was, right? In my fun class, Payers Gone Wild, which is out on the webpage. Remember, all of our classes are out there for free, and that one in attacking Medicare Advantage challenges. These are the two that I'm teaching the most. And interesting, let me give you the hot topic of both. Side of service. The number one issue is that the payers, United, the Blues, Humana, they're all stating that they will authorize care, but it will be at the lowest, at the high value facility, which means low charge facility. So when you get your prior authorizations, read them, because you could ask for a prior authorization for an MRI, and the doctor is part of the hospital requests it, but the authorization is for the freestanding imaging center an hour away.
Yep.
So you didn't get the business, even though and we're so used to always getting it. If the hospital asked it, we have it done at the hospital. Outpatient surgery, second one. Imaging is huge, and it's been around for at least a year, but now all the payers are doing. So CFOs, you cannot keep saying your charges are double the imaging centers because we have so many costs. You know what? United doesn't care. They're sending them to the imaging centers because they have to pay less to them. So again, why'd you contract with all these payers when they turn around and contracted with the competition who charge less because they're freestanding? They don't have the cost. How about surgeries? Second site of service, outpatient surgeries. These are huge, guys. United has published that their goal never to have an outpatient surgery done in a hospital again. You charge too much to the plan. So the allowable for you is higher than the allowable for the freestanding, and it's a carpal tunnel surgery. Right. Why would they ever authorize to you again? And they've been pretty blatant about, we have every intentions of never. So the hospitals become inpatients only, if you think about it. Mm-hmm. Your payers are doing this. You've got to sit down and say, we're not going to contract with you if you contract with everybody else, right? Because what do I get out of the contract? Now it's become obvious side of service is the kicker, and it hurts a lot. And you should read what they're all saying. It's very clear. Hospitals, get your charges down. And every one of you now, because of transparency, you know what everybody's charging. There is no secret, dudes. So you can all see what each other has, and you've got to compete. You just have to. And all of our excuses, it's so complex. Patients don't care. Blue Cross didn't care when they told Darrell and my husband, who had surgery, we could go to the hospital I wanted to have the MRI done at, my community hospital, or I could go to the freestanding 2 hours away. If I chose to go to my hospital, I would be penalized out of network, because the side of service was only approved for the one 2 hours away. Yeah. And we drove 2 hours. Wow. And now the cost of gas is ridiculous. But think about what they said. They approved it, but they didn't approve it where I wanted to go because their charges were too high. Because I called. And boy, when you start working through this, it's a big rev cycle issue. Huge side of service, big one. Yeah, I imagine so. Yeah, I feel like a lot of hospitals, when it comes to their payer contracts, I feel like they have them over a barrel. But like you said, some of the things they can do proactively, make sure that their pricing's in line and whatnot, so it doesn't stand out so much to the average consumer.
Now, I've asked some people about the impact of price transparency and
Yeah.
has that been a disruption? I will tell you, and maybe you've heard differently, but I'll tell you to a large extent, folks don't believe that it's been that big of a deal for them to comply with that, and it just hasn't caused a lot of incoming inquiries from patients or whatever. What are you hearing around that?
I think I'm hearing it isn't being done well, that patients can't access it. Again, the law
Some
says I
hospitals
shouldn't
aren't
have to have it.
compliant. Some hospitals aren't
Yeah, they
compliant
did.
with
There was,
getting-
yeah, the most
it's hard to
recent
find.
survey showed that 30% of the hospitals had done nothing to comply. They'll just pay the fine, which now, of course, Congress is back going to say the fine must not be enough because we want our patients. They want our patients. We should want our patients. Joe Pfeiffer talks all the time about consumerism. What's consumerism if it isn't transparency?
Right.
I have to know what my charges are going to be. I have to know what I'm going to owe out of pocket. Now, the good news is on transparency. Remember, the payers in 2022 will be required to post their high 300 shoppable services as well. So, but I think, Bill, the problem is because patients don't know how to access anything. And the law says it's supposed to be not tied to any passwords. It's supposed to be easy to do. Have you ever tried it yet to any hospital? I'm writing a series of articles on transparency, and I am being a patient, and I'm going out and I'm just working with a bunch of Idaho hospitals. They don't know anything. I'm just trying to look up, trying to have a surgery, trying to have something done. And I am trying to get estimates, and I am trying to get my Blue Cross plan or my Pacific Source allowable. So far, I've had zero success in making it happen. I had to call both times, and I explained to them it wasn't working. And I said, and I know how to do it, and I can't do it.
Yeah.
So it might be patients just get because they just get frustrated and don't bother to try. But
Sure.
I think we all speak to consumerism, and if that is this, patients want to know what their charges are going to be, what their allowable is, what they're going to owe out of pocket. I don't know any other definition of consumerism. This is the big one for us.
Yeah.
So I'm a little disappointed with how the stats are coming back, that we'd rather pay the fine than do it. And they're mostly worried about the allowable, so the payers everybody can see each other's rates.
Mm-hmm.
But, Congress is going to come back and add some more penalties because those kind of national surveys are not doing us any favors.
Yeah. Yeah. No, I hear you. Well, I so enjoy talking to you. There are a lot of additional topics that we can cover. Is there anything in particular from your perspective that we missed today that you wanted to make sure we touched on?
Oh my gosh. No, other than it is just wonderful to know that we have a potential soon to see each other and to do the COVID hug. Remember, we got the COVID hug down. We know how to do that.
That's right. Right.
And
Turn your head.
Turn your head, mask on, vaccinated, mask on, turn head, hug. I practice this with my grandchildren. After a year of not hugging them, I said, okay, we're gonna do the COVID hug. And we laugh about it, and we need to be okay doing something like that soon. So I look forward to that. And I told you when I got on a plane for the first time, I was rookie queen, and I want some humor. It's kind of good to have a little humor. And Bill, you're so good for that, to bring humor back to us and to really care about each other. What have we learned? That I will tell you one funny story. With the mask on, eyes are our greatest feature. There we go.
Yeah.
Everybody does everybody tell you that? What's your best feature? Oh, my eyes.
Right.
And then put a mask on, and guess what? It's your eyes that are best feature.
Right.
So we've laughed about that too. I have more makeup on my eyes than I used to have.
Something I've been doing the last several weeks on my LinkedIn page is I'm taking healthcare cartoons, and I'm putting the picture of the cartoon on there without a caption. But
how fun.
There's a healthcare theme, and I'm encouraging people to caption the cartoon.
Oh, how cute is that?
Yeah, I've been doing that for maybe the last 4 or 5 Wednesdays that I'll put that on my LinkedIn page, and I've gotten some great responses. They make little pokes at the insurance companies. They talk about COVID and everything else.
Yeah.
Again, just trying to keep it light. And I would tell people, you and I both, I think, generally see the glass half full. We try to be positive. We've both had to pivot in our roles as business people in the last year. But I would just encourage people to keep moving forward. We're not quite where we want to be yet, but as I've said before, and maybe you've heard me say, we are a little bit better than we were yesterday, and so it's just one day at a time, one step at a time. Believe in what you're doing, let that show in how you present yourself to other people. It's okay if you have a down day, everybody does, right? But just try to bounce back from that and know that the sun will come up again tomorrow, and we'll do our best to navigate this thing together. But I can't encourage people enough to take advantage of the resources, the relationships, the associations, the HFMAs and the AHAMs and the NTMAs and just all of the other smaller groups that have come together in healthcare. Take advantage of your relationships and staying connected with people to help find the solution. Don't shut yourself down and put your blinders on and think that your way is the only way, or that your organization's way is the only way. It's so important to collaborate right now. And so I would really encourage people to hang in there.
I would too. And I have a phrase for that. And my children would probably be chuckling, going, I know what my mom's going to say. I know it. It's called the bootstrap day. There are just days that are bootstrap days. Pull them up, get going. And It's okay. I mean, I've had to do that with my own self, and I know you have too, especially if I have not had COVID, thank God, but a lot of my family members did. And those days were bootstrap days. And then I'll see something happening on the national level that I just go aghast, and it breaks my heart. And it's like, all right, it's a bootstrap day. I got to keep moving forward. I have to believe the best in people, even though there are days that's very hard. And then I realize it's a bootstrap day. My mother would say, you do know that this day will be better tomorrow. Absolutely. And I hope we instill that in all the people we have the privilege to touch professionally and personally. My children and grandchildren, we all have family. And by the way, I have to show you all my pictures. I have to show Bill. I want you to see my pictures. These are all my family pictures back here.
Isn't that great?
So
yeah,
this is my family room. This is my office, and my entire back hall. But the back of my office is covered with my family pictures.
That'll keep you in a good mood. That'll keep you positive.
Yeah, it does.
Well, I wish you all the best. You've got some speaking dates in person coming up in the weeks and months ahead. I know you're going to be in Alabama in early June, Alabama HFMA. What are any others that I'm forgetting about? Probably
at this point,
Region 8 in August.
I'm not sure. I think Region 9 for sure in New Orleans,
which you said has been moved, starting with.
It's been moved so that it can work around the new ANI, which is annual conference in November. Yep. And so a lot of them right now are still virtual. So the ones that I'm doing, which is fine by me, I think we need to be so creative to reach many, many members and non-members.
Yeah.
So face-to-face is exciting, but let's do hybrid. Let's keep doing virtual so that we can. And right now, it's kind of been each chapter I've been privileged to speak to, like Nebraska's coming up. They voted to stay virtual this time, and that we'll just move to the next chapter, just the next meeting, and try it. I think in the fall, we're going to be doing some face-to-face boot camps for HFMA by the chapters, and we'll see what the fall looks like. If we've had another horrible surge, we'll flip to virtual. Yeah, I mean, the good news is we know how now.
My gut tells me it's going to gradually get better. I think we'll be okay come the fall. So we'll see, but
I hope so too. And it feels right. When, like I said, I've had to take baby steps to go face to face. So virtual is what we've all real I'm very comfortable with virtual now, even though that means I have to put on makeup and everything.
Yeah.
You look sure. This is crazy, natural, curly, crazy hair going on here. But it's fun. It's fun to know that we can just reach out in so many different ways now. And I love that.
Well, there are a lot of ways for people to connect with you. You're a wonderful source of information and education. There's all kinds of resources available on your company website, and I'll make sure I include that when I post this. But I wish you well, stay well, and I so look forward to visiting with you again really, really soon.
I absolutely as well. And Bill, we're going to practice the COVID hug. COVID hug, turn head, mask on. We're hugging, dude. We're hugging.
That's it.
Love you. Bye, everybody.
Take care.
Bye. Take care of each other.